Very good evening, everyone, and thank you for coming on to this very informative and educational webinar. Can we start?
Yes, sir.
Right. Good evening, everybody, and thank you very much for coming on to this very educational and a very important webinar. It's a great honor and privilege for me to introduce to you two very renowned and senior clinicians who would be joining us today. It gives me pleasure to introduce Dr. Usha Rani from Hyderabad. Madam is the professor and HOD of pediatrics at the Osmania Medical College, Nilofer Hospital, Hyderabad. Madam has been awarded her MD in pediatrics from the B.R. Ambedkar Medical College, and she is held on the position of professor and HOD of pediatrics from October 2017. With more than 10 or plus publications to her credit, Madam has also been part of various clinical trials, which include, the use of nebulizer budesonide for asthma in children, the WHO IPV phase 3 trial, the phase 3 vaccine trial for pentavalent vaccine, and the rotaviral surveillance study. Thank you, ma'am, for your time and coming on to this webinar. It also gives me an honor to introduce to you Dr. Chetan, who is the pediatric intensivist from Aster CMI Hospital. Doctor has international and national training and has also been responsible for coordinating the pediatric organ transplant program. A graduate of the King's College in London and the reputed PGI Chandigarh and the PGIMR Pondicherry, Dr. Chetan has been the proud recipient of the Rotary Vocational Excellence Award in the year 2013. Doctor is admired by his patients for his nature and commitments towards the care of children and boasts of more than 5 memberships, that is the Indian Academy of Pediatrics, the Respiratory Chapter, the Indian Academy of Pediatrics, the Intensive Care Chapter, and he is also part of the Society for Trauma and Emergency in Pediatrics. Doctor has written more than 25 articles for peer review publications as the Indian Journal, such as the Indian Journal of Pediatrics, Indian Pediatrics, Biomedicine, and the Current Pediatrics. Thank you so much to the both of you for coming on to this webinar and helping us improve our knowledge. Ma'am, we would like you to share your slides first and lead the presentation. Thank you.
Yeah, thank you, Siddharth, for the kind introduction. A very good evening to you all. Yeah, at the outset, I would like to thank Fisher-Paykel for this opportunity and for taking an initiative to conduct this session, which is so important at this time when we are anticipating COVID third wave, which might affect children, but I hope it should not come true. But whatever it is, we have to be prepared. And with the governments focusing more on child care and pediatric COVID, many of the district hospitals have also got PICUs and pediatric wards with the anticipation of third wave. And now HFNCs have been supplied to all the government hospitals. So all the pediatricians must be aware on how to use HFNC. And as you know, HFNC is a non-invasive mode of ventilation, by using which we can avoid the adverse effects of artificial airway, that's the effects associated with intubation like ventilator-associated pneumonias, barotrauma, volume trauma, etc. And also in a pandemic like COVID, where large numbers of patients might need ventilation. So it is not possible to provide ICU care with ventilation for everybody. So moderate cases can be managed with non-invasive ventilation. So the importance of HFNC has grown tremendously in the last 2 years, the last 1.5 years, I would say, especially during the second wave of COVID. Most of the adult units have extensively used HFNCs, though pediatric load was lesser compared to adults. Then coming, what is HFNC? So in this today's CME, I would be talking more on basics, what is HFNC and how to start there. And as we have the privilege of having an intensivist with extensive experience with us, he would be sharing the critical care aspects and in-depth about the HFNC usage. First of all, what is HFNC? So the full form is heated, humidified, high-flow nasal cannula. But generally, we use the term HFNC for commonly. So by definition, the Cochrane review of 2014 has defined HFNC as a heated delivery of heated, humidified, high-flow oxygen through a nasal cannula at a flow of more than 2 liters per minute, humidification of 100%, and temperature little less than the body temperature between 34 to 37 degrees centigrade. And this provides high concentration of oxygen and also continuous descending pressures. And why HFNC scores over the conventional oxygen therapy? So oxygen, as we all know, is a dry gas. And if you use it for a long time, it can cause dryness and irritation of the mucous membranes. So dryness can, and also cool air, they may interfere with the respiratory epithelial ciliary function. So the airway mucosa or the bubble humidifier, which we use along with nasal prongs, that will not provide adequate humidification for gas flows more than 3 to 5 liters per minute. So it is absolutely essential to humidify and heat the air oxygen mixer whenever we are using supraphysiological rates, flow rates. Then what is coming to the basics of the instrument? Most of you may be familiar. This has a blender. Is the main component is a source of pressurized oxygen and air, which is regulated by flow meter and a blender. And it has a sterile water reservoir, and also it has a humidifier and also heated circuit. And here you can see the interface, which is a non-occlusive interface compared to CPAP. How does HFNC act? So this is a mnemonic which is commonly used, HIFLOW. This is H stands for heating and humidification. So how does heating and humidification helps? So the epithelial function is well preserved when you give a warm air, warm gas. So the secretion clearance is better, the airway inflammation is reduced. And also when you humidify the air, the evaporative losses from the respiratory mucosa are significantly reduced, and that significantly reduces the energy expenditure and metabolic demands. The higher inspiratory flow, it reduces the inspiratory resistance from the nasopharynx, and also the alveolar, the patent at the end of expiration that improves the functional residual capacity. And this warm humidified gas is lighter, and also it is more comfortable and easy to use. And because we are using supraphysiological rates, higher flow rates, there is no dilution with the room air. So the oxygen dilution by room air can be minimized. And another greatest advantage is the dead space is washed out. The nasopharynx is continuously replenished. So there is better removal of the exhaled air, and carbon dioxide retention is also would be minimal. So thus, on the whole, there is reduction of dead space, there is dynamic positive airway pressure. So with a flow rate of more than 2 liters per minute, the esophageal pressures are constantly maintained above 4 centimeters of water compared to conventional low flow oxygen therapies. And compared to CPAP, patient comfort is also better. And also we can have a predicted FiO2 delivery. So because if with low flow, there is dilution with the room air, the FiO2 which we deliver is not constant and it is variable. Whereas with HFNC, we can deliver predicted FiO2s. And compared to CPAP, because it is not an occlusive interface, the patient comfort is better. Actually, neonates, even KMC, developmentally supportive care, can be better maintained with HFNC compared to CPAP. And also nasal trauma is less compared to CPAP because the cannula does not occlude the nostrils completely. And coming to the clinical applications, HFNC has been widely used and has become a part of NICU care for the last decade. But in pediatrics, not many studies, there's no much robust evidence. But the only condition in which it has been extensively used is bronchiolitis. So bronchiolitis is a very common, in fact, cause for admission in pediatric intensive care units. And traditionally, we were giving, there's no specific treatment and oxygen is the only treatment. And we were giving low flow oxygen with nasal cannula. If it fails, we were giving CPAP. And then if there is no response to that, we were giving mechanical ventilation earlier. But with the emergence of HFNC usage in pediatric critical care units, HFNC has become a very important mode of oxygen therapy in patients with bronchiolitis. And definitely usage of HFNC has led to reduced intubation rates, reduced admission rates in the PICUs, and reduced usage of CPAP. This is a very large study, and if you use HFNC in the emergency department as a primary mode of oxygen therapy, we can significantly reduce admission rates to PICU. So this is a pediatric acute respiratory intervention study, which was published in New England Journal of Medicine. This is a large multicentric study, including 1,472 patients, wherein compared to standard oxygen therapy, that is with low flow oxygen therapy, the usage of HFNC as a primary modality of oxygenation in emergency department has significantly reduced the rates of admission to PICU and reduced the rates of therapy failure. So therapy failure rate were 12% in HFNC group compared to 23% in the standard oxygen therapy group. And coming to, apart from bronchiolitis, what are the other indications where we can use HFNC? Pneumonias, including COVID pneumonia, asthmas, and HFNC is extensively being used in many of the PICUs for acute heart failure with pulmonary edemas. And also, as I mentioned earlier, use of HFNC in emergency department significantly reduces the admission to PICU, and also significantly reduces the PICU costs. And for transport, so many Australian and American experiences have shown that if we transport the child on HFNC instead of standard oxygen therapy, then on retrieval, the number of children who require invasive ventilation has been significantly reduced. And also HFNC is a very good modality for post-extubation respiratory support. If we use standard oxygen therapy, the extubation failure rates are higher compared to HFNC, and HFNC efficacy in reducing the extubation failures is comparable to CPAP. And also, if there is a difficult extubation, for pre-oxygenation also HFNC can be safely used, and it is more effective than low flow oxygen therapy. Coming to role of HFNC in COVID, definitely IAP recommends usage of HFNC for COVID pneumonias, but only problem with the NIVs is there is a significant aerosol generation and transmission to healthcare workers might increase. So we have to take all airborne precautions, and ideally it should be managed in, these children should be managed in negative pressure rooms, and healthcare workers must wear PPEs, and over the interface we need to put an oxygen hood that will reduce the airborne transmission to health workers. As the number of children with COVID-19 were less, there are not many large studies on HFNC usage in COVID-19, but there are case reports with success rates. This is an adult study where usage of HFNC has had a success of almost 47%. So 137 adult patients out of 293 could be treated on HFN. So in adults, it has been established. In children, we do not have any large studies. So this is a study done in neonates comparing HFNC versus CPAP for post-extubation respiratory support. And this study has found no significant difference statistically in the rates of extubation failure in the CPAP and HFNC groups. Moreover, HFNC has resulted in lesser nasal trauma, and it was better tolerated compared to CPAP in these neonates. This was a huge study done in 432 infants with a gestational age of more than 28 weeks. Then are there any, having known indications, are there any contraindications? So definitely we cannot give when the child is in altered sensorium and there's no spontaneous breathing. And also if there's any upper airway obstruction, there is epistaxis or basilar skull fractures, or if there is recent nasal surgery, we won't be able to start HFNC. It is contraindicated in these situations. And coming to the implement, how to put it at the bedside, how to choose a interface. So the various sizes available depending on the size of the nostril. So based on the weight, so we have to see that the cannula size should be around 50% of the diameter of the nostril. It should not occlude more than 50% of the diameter of the nostril. If it is too small, you won't be able to deliver good flow rates. If it is too big, it will increase the pressures pressures delivered. So you have to be careful that it doesn't occlude more than 50% of the diameter of the nostril. Then what are the variables while setting up? So the three variables: temperature is set at 1 to 2 degrees below the body temperature. So ideally, the temperature delivered at the nares should be around 34 degrees centigrade. And the flow start with 0.5 and it can go to a maximum of 2 liters per kg per minute for the first 10 kgs. After 10 kgs, you can add on 0.5 liter per kg beyond 10 kg and should not exceed 50 liters per minute. And the FiO2 start at 0.4 to 0.6. You can increase up to 1 and the target saturation should be around 90 to 95%. And after starting HFNC, you need to monitor the child assess the child after 1 hour. And then the monitoring parameters are heart rate, respiratory rate, SpO2, FiO2, and temperature. And you have to set a SpO2 target should be around 92 to 97%, and FiO2 should be less than 0.4%. If there is improvement in heart rate and respiratory rate and decrease in FiO2 to less than 50%, we can say the child is improving. If there's no decrease in heart rate and respiratory or no improvement in saturations, then you have to step up the therapy. You have to escalate the therapy. There's one index which is used to predict success or failure of HFNC, which is called ROX index. This is nothing but respiratory rate and oxygenation index. If this is calculated, SpO2 divided by FiO2 divided by the respiratory rate. If it is more than 4.8, it indicates that the patient will do with well with HFNC. And you need to do this at 2 hours, 6 hours, and 12 hours. But you should not depend only on the parameters, but you also look at the clinical condition of the patient. How is the sensorium? How are the retractions? So they're more important along with these parameters. So this is a flow chart. So how to initiate and how to titrate. So the basal parameters, the temperature, FiO2 and flow we have discussed. So after starting, you need to monitor the heart rate, respiratory rate, and SpO2, and also the level of sensorium and also chest retractions. So if there's improvement, we can continue monitoring till the respiratory parameters are stable for at least 24 to 48 hours. So if there's no improvement in the heart rate, respiratory rate, retractions are persisting, then you can increase the flow up to 2 liters per kg for first 10 kg, then 0.5 liters per kg till a maximum chilling is achieved. And the FiO2 can be increased next. First flow should be increased, then the FiO2. If there's no improvement or worsening, we have to label it as HFNC failure and we can go for invasive or non-invasive ventilation. But throughout the course, you need to check the sensorium at any point of time. If there are any signs of respiratory failure, respiratory acidosis, or SpO2 is decreasing, then you have to escalate the respiratory therapy. If the child is stable for 24 to 48 hours of HFNC, the first thing to be weaned is FiO2 to 0.3 to 0.4. And then you can reduce the flow by 0.5 liters per kg every 4 to 6 hourly. And continue to monitor. And if the child tolerates the weaning well and reaches a flow of less than 0.5 liters per kg per minute, with the FiO2 of less than 0.4, if the child is able to maintain SpO2 of more than 92%, then you can stop HFNC and you can put the child on room air, or if needed, you can put on nasal cannula. So this is the titration and monitoring while the child is on HFNC. And another good advantage of HFNC, if the child is stable, the feeding will be very convenient compared to an IV delivered through a mask, because it is a very soft cannula and the mouth is open. So feeding can be continued. But if the child is struggling and is at risk of aspiration, then you have to put the child on nilorally. And the very few side effects, it can cause for prolonged periods of use, it may cause some abdominal distension, and very rare cases of air leaks have been reported. So to conclude, so HFNC is emerging as a very good modality for oxygenation in various pediatric conditions, especially bronchiolitis, and now in COVID-19. And it has very good safety profile. There's no need of good advantage is that sedation is required. Sedation is not required. Children tolerate this better. And also parents are also happy. They're more satisfied compared to a mask-based NIV, because mask is not comfortable and children struggle with it. And mask also can cause nasal ulcers. Similarly, CPAP also, there is septal trauma. So all this can be avoided by HFNC. And there is a need to create awareness across the all the hospitals in public as well as the private sector We also got a lot of equipment for COVID third wave preparations. We got more 100 HFNC machines. And I think after 6 months, we would be able to generate some studies. We're planning to do a trial also on HFNC, planning to do a study. And maybe after 3 to 6 months, we'll be able to produce good evidence on usage of HFNC in pediatric care. Thank you. And with this, I hand over to Mr. Siddharth. Probably Chetan can take over.
Thank you, ma'am, for your insightful presentation. I request Dr. Chetan to come on board next.
Stop sharing.
So is it visible now?
Yes, it is.
Yeah. Hi, good evening, everyone. And thank you, Dr. Usha, for that great introduction about the topic as such. So I will also there will be some overlap in what we have discussed so far with Dr. Usha's presentation. But I will more touch on few specific aspects with respect to the versatility of the HFNC, how it can be used in different clinical scenarios, not only respiratory, but also other illnesses or comorbid conditions which happen in the ICU. The comfort factor which the HFNC produces, which the other modes of oxygen delivery do not. And we will go through a few real-life cases from our own practice and see how HFNC has benefited these patients, both in terms of preventing invasive ventilation and providing care which is also comfortable. So just we'll go through this kind of an overview history. I will just touch upon the applied physiology again. And where does HFNC stand in terms of the overall pre-invasive or non-invasive respiratory support therapy? The key when we use HFNC is to know when to use it and when to escalate from HFNC to an invasive mode of ventilation. So that is a very critical decision which we need to take when we are using it in an emergency scenario, when we are using it in the ICU setup. The structure of HFNC already Madam has described. How does it work? We will kind of touch upon what is the current evidence, and we'll go directly into the case scenarios and discussion. And also I'll take the liberty of summarizing the take-home messages for all of you from both these talks. So since the time the oxygen was discovered as a gas, the initial oxygen delivery systems were all kind of rubber tubes, catheters, which were inserted in the nose. Sometimes even today in very busy units where we do not have prongs, sometimes we use feeding tubes or sometimes indigenous CPAPs with nasopharyngeal access using endotracheal tubes for that. But these were the olden days oxygen delivery systems where a rubber catheter was put. At that time, there was no compressed gas as such, so the flows were primarily low. In 1920s, there were mainly metal cannulas, which was then replaced with rubber-tipped metal prongs for comfort and to prevent trauma and bleeding when we are using metal prongs. And then with the discovery of plastic, most of these tubings changed to plastic. Even modern oxygen deliveries in many of the units are still low-flow nasal prongs, which we use. Simple face mask, humidified high-flow mask, Venturi-style mask, or kind of NRM masks, which are used in the emergency settings. Here, we can use slightly higher flow rates when we are using face masks, but then to concentrate the oxygen in the reservoir, which is the natural reservoir of nasopharynx and pharynx, when we use a simple face mask, the FiO2 delivered ranges somewhere between 40 to 60, and it increases to 60 to 90% when we use a non-rebreathing mask, where there is an external reservoir attached to the oxygen face mask, which also enriches the rebreathed air, and the concentration of the oxygen in the natural nasopharyngeal reservoir goes up, that thereby increasing the FiO2 of oxygen delivery. Now, what has happened in the last 80 years is that the oxygen delivery has barely changed. What this oxygen is causing, with the oxygen which reaches to us in the wards and the ICU, usually comes from a manifold which has got large oxygen cylinders compressed into a liquid form and then released into a gaseous form. It goes through copper tubings and comes out through the oxygen flow meters in our ICUs and wards. It is in a very dry and cold form, the temperature of which is close to 5 degrees, and it is very dry. So this dry, cold air causes more energy expenditure because the body has to kind of heat up this oxygen and humidify it, and thereby the insensible losses go up. The patient discomfort and stress by a blast of cold, dry air into the nostrils and the nasopharynx is very discomforting, and also sometimes prolonged use can cause the drying of the mucosa, chapping of the mucosa, epistaxis, and these kind of bleeding tendencies can happen. So the heating and humidification provides the comfort which the earlier oxygen delivery systems were not doing it. Also, the dry cold oxygen ticks up the secretion, makes it difficult for the patient to expectorate, spit up, or swallow, and the secretions become more difficult to bring out. When we use dry cold oxygen, we cannot use high flows of the order of 0.5 to 1 liter per kg or going up to 2 liter per kg for more than 2 to 3 minutes. That can be used only during the peri-intubation stage for what is known as an apnea oxygenation. We do not and cannot use such high flows in the ward setting or an ICU setting to meet the oxygen demand as such, because such high flows of cold, dry air is really going to cause severe mucosal trauma and bleeding. Now, if we cannot use such high flows, we will not be able to meet the inspiratory demand of a child who is in respiratory distress, be it whatever cause. It can be a respiratory cause like pneumonia, ARDS. It can be a hemodynamic cause of increased oxygen demand like shock. It can be pulmonary edema. All these conditions put an extra stress on the respiratory system, and the child, when he is breathing harder and faster, that inspiratory demand cannot be met by this low flow oxygen. And the oxygen delivery, as you saw, in a stressful situation with a face mask which is not fitting correctly, there is a lot of leakage and dilution with the ambient air, and that results in an inaccurate oxygen delivery system. There are multiple interfaces required, multiple sizes required, and more often than not, it results in treatment failure, resulting in escalation of therapy. Now, what is the escalation of therapy? It is primarily invasive ventilation and intubation. So current day, from 1960s, when the compressed gas was available through the cylinders, the compressed gas was delivered. But now we are able to deliver still higher flows just by the virtue of heating and humidifying the gases as such. So in the new era, where we use the high flow nasal cannula oxygen, the goal is primarily to optimize the spontaneous breathing. And how does it do it? So Madam alluded to that to some extent. There is reduction of the overall dead space. The anatomical dead space extends from our nostrils to the nose, nasopharynx, pharynx. Then comes the trachea and the main bronchi. And then it divides into almost 30 generations of airways before it reaches the respiratory bronchiole, where the gas exchange actually starts. Now, when the child is either in distress, we would want to deliver as much oxygen concentration as much as possible, and also remove the carbon dioxide in this anatomical dead space, which is not taking part in gas exchange. By using high flow as such, which is flows exceeding around 2 liters per kg, we are able to wash away this anatomical dead space and replace the dead space by fresh gas, which is also heated and humidified. This high flow also acts as an internal stent. The column of air which comes out of this HFNC and enters through our nasal cannula is also able to maintain a dynamic positive airway pressure, acting as an internal stent. And that is why the usage of HFNC in upper airway obstructions like tracheomalacia, bronchomalacia, and also providing a reduction in the breathing efforts in pure alveolar disease like pneumonia has been significantly there. The other three major benefits of using HFNC: airway hydration, this we discussed in detail; supplemental oxygen, more accurate supplemental oxygen where we can really titrate the FiO2 which we want to deliver to the patient; and most importantly, patient comfort. The patient can talk, can interact with the caregiver, we can feed, we can even feed NG tube, we can feed oral feeding to a child who is already on HFNC, and that makes comfort care much easier in these children. So the overall physiological outcomes when we use HFNC is primarily reduced respiratory rate, reduced work of breathing, reduced carbon dioxide, increasing tidal volume by virtue of dynamic airway pressure, and prevention of alveolar collapse, increased end expiratory lung volume. So the FRC is slightly increased, improved mucus clearance because the dry tenacious mucus is no longer present, and the airway hydration, mucosal inflammation is reduced, thereby reducing mucus production, and whatever is produced is easy to clear out, and also oxygenation. So in the whole gamut of the non-invasive support that we want to give to a child, where does HFNC fall? Now, when we talk about non-invasive support, there is variable airway pressure, which is primarily the nasal BiPAP, nasal high frequency, and the constant airway pressure, the classical example being CPAP, which can be again a very device delivered CPAP, which has got a constant flow, or a variable CPAP, which we use in an indigenous bubble CPAP. When it comes to nasal cannula oxygen delivery, there is either a low flow nasal cannula oxygen, which is the direct nasal prong, which we connect from the flow meter in our wards, or we can use an HFNC device, which filters, humidifies, heats, and then delivers this oxygen in a better way. Now, when to use HFNC? It is very important to understand the physiology of respiratory distress, and at what level we can initiate non-invasive support, at what level we can initiate HFNC, and what level we should escalate the treatment when the outcomes or the the slopes become very unpredictable. Then it's better to go in for a more definitive airway and invasive forms of ventilation. Now here in this, we are kind of seeing the normal PaO2, PCO2, and in the normal child who's not having any respiratory distress, but he has got other comorbidities, especially maybe shock, maybe intra-abdominal surgery, recovering from anesthesia. So these are conditions, or during transport of a child post-ictal state, we will be able to deliver oxygen in a better way using HFNC. Now, when there is an early respiratory failure, that would mean that the child's oxygen levels are going down, saturations are dripping, PaO2s are down, but somehow the increased work of breathing is able to compensate partially, and the carbon dioxide is not not elevated. It is actually falling down because of our increased efforts. So when in this bracket of patients who are having dropping saturations, maintaining carbon dioxide, and the compensatory mechanisms for the respiratory distress have been initiated by increased work of breathing, tachypnea, that is the time when HFNC and non-invasive ventilation will work. But once it crosses that stage and there is a complete unpredictability in which way the patient is going to go, whether a simple hypoxia may turn into other organ dysfunction, brain, heart, if that gets affected, in that case, it is better to draw a line and switch over to invasive forms of ventilation. So the scope of NIV is primarily till the compensatory mechanisms are intact. There is only a hypoxic respiratory failure. And the scope of HFNC also is similar, where we can, to some extent, support the respiratory distress when the child's PaO2, PCO2s are kind of within the compensated range. But once the slopes are kind of, the child is dipping, then it is better to take over the complete ventilatory aspect. So not wiser to use NIV when the PaO2 and PCO2 trajectories are unpredictable. So this is very, very important. That is why in the emergency room, while transporting, or the initial 2 hours to 4 hours of admission of a child in the PICU, we need to monitor the patient well and find out from the early respiratory failure phase, is the child moving towards some normalcy, or he is deteriorating towards a late respiratory failure. So the clinical indications extensively studied in bronchiolitis, in pneumonia, congestive heart failure, very well tolerated during the post-extubation phase. The children who have some glottic edema, it acts, as I told, as an internal stent, and the post-mechanical ventilation, weaning therapies from mask CPAP or BiPAP, respiratory support to children with neuromuscular disease. If there is an intercurrent decompensation which happens to children with neuromuscular disease, they have got an intercurrent pneumonia or an aspiration, then instead of putting them on ventilator and managing the complication of invasive ventilations like VAP, like critical care neuropathy, and myopathy, on top of a neuromuscular illness, it is better to provide them support with HFNC and manage the other comorbidities and reduce the overall stay of the patient in the ICU. Apnea of prematurity is one more condition in the NICU. We constantly use HFNC. So we should know the triggers to initiate HFNC and escalate from HFNC to an invasive form of ventilation, or even to a kind of non-invasive ventilation like a mask NIV. Now, if you have to look at this slide, there is a patient age level, 0 to 3 months, 3 to 6 months, and so on. In the green sector is the normal respiratory kind of rate in terms of breaths per minute. Now, when the child is on the right side of this normal trends, normal breath rates for that particular age, then is the time when we call it mild to moderate respiratory distress. And the first line of respiratory support needs to be in the form of some form of oxygen therapy or HFNC if despite standard oxygen therapy, there is hypoxemia and saturations less than 92%. Now, so the mild respiratory distress, how do you define it? It's defined by simple dyspnea, tachypnea, shortness of breath, no obvious increase in the work of breathing or accessory muscles. Child is able to speak sentences. There is stridor, but then it is not obvious airway obstruction. Stridor becomes manifest only when the child cries as such, and mild shortness of breath on exertion. And moderate respiratory distress can be increased work of breathing, restlessness. CNS effects have started, child becomes more anxious, there is tachypnea, hyperapnea, increased muscles of accessory muscles usage. You will see retractions, subcostal, intercostal, nasal flaring, sternocleidomastoid, head bobbing, retractions of flaring appear, and just child starts speaking in interrupted sentences. There is stridor, but not always protected, and a prolonged expiratory phase, which happens in asthma. Now, this is kind of great overlap in all these conditions, but these are situations where you can use HFNC to initiate an oxygen delivery system in addition to the heated, humidified, high flow nasal cannula oxygen. So if you are comparing the HFNC with the other two modes of oxygen support, which is a low flow nasal cannula oxygen or a nasopharyngeal CPAP as such, so the patient interface remains the nasal cannula. However, the HFNC nasal cannulas, which are available, especially the Fisher and Paykel ones, have got a wiggle. It really anchors it very well onto the cheeks. It does not move with the movement of the child's head. And even if the child is rubbing his nose or reaching out to his mouth or using a pacifier, it doesn't get dislodged very easily. But that is not the case with the stiff nasal cannula, which we see usually in pediatric and neonatal age group, which keeps coming out, and it is very difficult to anchor it unless we use plasters and things like that. So the HFNC is heated and humidified, and the pressure is kind of variable and unregulated. So the flows which we use in HFNC and CPAP is slightly higher, so more than 1 liter per minute, going up to 2 liters per kg per minute. So the first thing which we need to remember is primarily select the patient based on the indications, select the appropriate patient interface, providing both comfort and the benefit of the flows without using a nasal interface which is too small or too big. Appropriate application of the patient interface, make sure that you hold the head still, apply the sticky pads and then the wiggle, and then secure the nasal cannula. It usually does not kind of pop out if you secured well. So prongs should not totally occlude the nares. It should occupy only 50% of the total surface area of the nares. Use appropriate fixtures and should not be moving or dislodging from the nares. So this we discussed. So usually in the pediatric age group, for infants, we use the purple one, and older children, we use the green one. In adolescents, again, there are different interfaces available, which we use closely to adults, because the maximum flow which a green cannula or a green nasal cannula will allow is around 25 liters per minute. So it can be used in a child who is 12 to 15 kgs, but a child is 20 kgs, 30 kgs, then it is better to use an adult nasal cannula, or there is one size above that, wherein you can go up to 30, and then there is a bigger size where you can go up to 60 liters per minute. So there is a limitation of flow depending on the size of the nasal cannula, and that has to be known by the clinician as such. So it is all mentioned in the back packet of the nasal cannula as such. So what do? We set the flow rate. If the weight is less than 10 kg, you can set it at 2 liters per kg per minute. If the weight is more than 10 kg, set flow rate at 2 liters per kg per minute for the first 10 kg and 0.5 liters per kg per minute for each kg above 10 kg. So start at a lower flow rate, let the child become acclimatized, and slowly increase the flow rate within the next 5 to 10 minutes. There is always a blender. The HFNC or the Airvo with the Fisher-Paykel has got a blender which will kind of, you just have to increase the oxygen rate, and it is measured onto the display in the HFNC machine. So initiate usually with 60% FiO2 and try to reduce it to 40% in 2 hours after initiating and reaching the target flow. For cyanotic heart disease, we usually maintain the saturations up to 75 to 85. For other indications, our target should be somewhere around 94 to 98%. The humidification has to be set at around 37 degrees. So by the time the heating and the heat reaches the nasal prongs, there is some loss of temperature, and it reaches around 34 degrees at the nares. So so just an initial clinical scenario just to make you aware about how to go about it. A 7-month-old child who weighs 6.5 kg, symptomatic last 10 days, delivered by a full-term normal vaginal delivery. He was well till 6 months, was started on low-flow nasal cannula oxygen in the ward. Saturation was maintaining between 88%. He was tachypneic, and the heart rate was also very high. Now, generally, the practical point I want to emphasize is, if you go by weight, usually for this child, the maximum flow rates which we can use is 6.5 into 2, it becomes 13. So should you use 13 liters per minute as such? So the general dictum is that the weight in infancy, in less than 1 year, usually we do not exceed a flow of around 10 liters per minute. That is mainly because the nasal resistance is significant in the first 1 year of life, and most of these the flow that you are going to use in excess is going to bounce back. So just remember, in infant you can use 2 liters per kg per minute, but not exceeding the net flow of 10 liters per minute. So that is the message I wanted to give you to this slide. Now, when the patient is put on HFNC, there are certain monitoring parameters which you need to do. And these monitoring parameters are physiological parameters of respiratory rate, heart rate, degree of chest indrawing, telling you about the work of breathing, and the saturation on the monitor. While we connect the child on HFNC, we should be able to reduce the FiO2 to less than 40% in 2 hours, because we have reached a flow which is supraphysiological, which is exceeding the maximum inspiratory flow, and that's by that virtue of using flows which are in excess of the maximum inspiratory flow generated by the patient, we are reducing the patient's work of breathing. There is also an overall comfort with respect to reduction in heart rate by 20%, respiratory rate by 20%, improvement in the chest indrawing and other signs of distress, and the saturation being maintained between 94 to 98. The reason why we, in respiratory diseases per se, respiratory diseases, pulmonary edema, early ARDS, we want to bring down the FiO2 to 40% is primarily to see if the saturations drop to less than 92% on high flow, and also FiO2 of 40%. If we use high FiO2 in these patients, suppose saturation is 92, you have a nurse who is there, she just increases the oxygen flow, the FiO2 goes up to 60%, 80%, 100%. Saturation is around maintaining borderline 93, 94, but you do not have any idea about the carbon dioxide. So when the patient is kind of hypoventilating or the lung parenchyma is involved bilaterally, as it happens in a very progressive ARDS, apart from saturation, we also want to look at the carbon dioxide level. And that gets masked if you continue to use a very high FiO2 and high flow as well. And sometimes we may be caught unawares and the child may go on to a hyperbaric respiratory failure or type 2 respiratory failure. So when to escalate from HFNC not achieving your clinical and the physiological targets, respiratory distress worsens, child is decompensating, hypoxemia persists even after high gas flow and FiO2 requirement persists and continues to be beyond 50%. If that happens, then it's better to escalate to, say, non-invasive mask NIV or an intubated or go ahead with invasive intubation and ventilation. So children, infants who presented with low respiratory rates and higher PCO2 levels are at increased risk of not responding to HFNC. So children who are in poor GCS post-ictal stage with bradypnea, hypopnea, peripheral neuromuscular diseases who are again a kind of having a type 2 respiratory failure, hypopnea, bradypnea, those children are unlikely to benefit from HFNC, do not continue for very long. We have to take over and escalate the care to invasive forms of ventilation. So as we discussed earlier, the green are the normal respiratory rates. Below that, yes, the indications are do not permit use of HFNC. So the message is bradypneic child is not a candidate for HFNC. So what are the nursing guidelines for HFNC as such? Keep nasogastric tube in situ. Once stabilized, we can start with nasogastric feeds. Regularly aspirate before pre-feed for air. Oral nasal care becomes important. If the child is on HFNC for a long time, we have to keep checking the humidification because the bottle of sterile water is hanging there. We have to use sterile water and not normal saline to be filled in the humidification chamber. Just remember that. If also what we also do is use saline nasal drops to clear the nose with some turbinate edema, which may happen, especially in smaller babies, and make sure that the nose doesn't get blocked if the humidification is not appropriate. Check nasal prongs in correct position, use proper fixtures, gentle suctions to keep the nose clear, and check humidifier water level every hour. So how do we wean? Once the child is improved, normal kind of rate of breathing, decreased work of breathing, return to normal cardiovascular parameters, tachycardia settles down, blood pressure is maintained. In less than 10 kgs, once we bring down the FiO2 to less than 40%, reduce the flow to 5 liters per minute net rate, and then you can change it to low flow nasal cannula oxygen and stop oxygen if the child remains stable. If it's more than 10 kgs, FiO2 less than 40%, change to low flow nasal cannula oxygen and stop oxygen if it remains stable. Usually there is no need for any slow weaning. If the child is remaining in ICU for other reasons, observation reasons, directly we do not switch to again LFNC. We go to 5 liters to 2 liters and then directly take off the HFNC as such. What other thing practically we do in the ICU is that the HFNC nasal cannulas are extremely comfortable to the child. Now, even when the oxygen requirement is below 5 liters per minute and the FiO2 requirements is below 40%, sometimes we connect the low flow oxygen, but we do not change the HFNC cannula, nasal cannula, which are very convenient. So on de-escalation from the nasal from HFNC, we keep the nasal cannula of the HFNC machine and connect the oxygen to that from the wall regulators. So just 4 case scenarios, just again to look at to tell you what kind of cases are managed using HFNC. This is an 8-year-old boy who came 16 kgs, failure to thrive, known case of pulmonary alveolar proteinosis, had chronic lung disease requiring lung lavage and a bronchoscopy by pediatric pulmonologist at timely intervals. So this is the therapeutic treatment to remove the excessive debris of mucosa and epithelium in the primary alveolar proteinosis. After the lung lavage procedure, which happens in the OT, it takes around 4 to 6 hours. 4 liters of warm NS were used to lavage both the lungs. And when they come out, they come out mainly on the ventilator because Usually we are depleted them of some surfactant, because of which again the alveoli are collapsible. We have to maintain certain pressure to reach the functional residual capacity. It takes 1 to 2 days of overnight of ventilation, and then the child gets extubated. The next day, child was kind of checked for oxygenation levels. X-rays showed no evidence of effusion or pneumothorax. There were baseline infiltrates which were present as a part of the chronic lung disease. Spontaneous breathing trial was done. ABGs were okay. Child was extubated to HFNC. Initially with high flows, it was 13 kgs. We used around 25 liters per minute, FiO2 of 40%. And this heating, humidification, high flow has actually helped to reduce the further airway inflammation. And within the next 24 hours, child was weaned off the HFNC onto room air. So this is a purely an alveolar disease. It's a transient disease. We need to provide a transient support, and a heated humidification, high flow oxygen is a good form of support without worsening the underlying condition. So case 2, a 6-year-old child who was 18 kgs, diagnosed with Wilson's disease, liver failure, has gross ascites, underwent a living donor liver transplant at our hospital. Child was shifted to PICU for post-transplant care. It was malnourished. There was very high drain output post-operative because of the pre-existing portal hypertension, and that takes some time to reverse. There were fluid shifts happening, the pain of surgery and agitation because of a large abdominal scar. There is a reverse T incision which these children have. So their rectus muscles and the abdominal muscles are not participating in the process of respiration. Planned for extubation on day 4-5, child chest X-ray showed low volume lungs, mildly hazy lung fields, wet lungs. Because post-transplant, our primary aim is to salvage the transplanted organ. So we keep them well hydrated, we maintain higher blood pressures, but it also has an effect on developing little wet lungs. And because of the post-operative capillary leak, most of these children will have wet lungs. We do not want to keep them intubated for very long because that has its own complication. These children are on immunosuppression right from the time inside the theater. They have got a new liver. Though we want to salvage the new liver, we want to provide good oxygenation to the new liver. We do not want to keep doing that by invasive ventilation. So usually we extubate these children in a much premature way compared to other forms of invasive ventilation. And this child passed this spontaneous breathing trial. There was occasional splinting of the chest. Hypoventilation existed because the child was having lingering sedation effects, because high dose analgesia, fentanyl infusion up to 3 mics per kg per minute were being used. Sedation was being used. So after assessing the child clinically, a call was made to electively extubate. The child was extubated, flow was kept at 2 liters per kg per minute. Initial FiO2, even though we advise that keep the FiO2s to 60 and bring it down to 40 for respiratory causes, here in a transplanted organ, we want to keep the PaO2s more than 100 because the new organ has to get an oxygenated blood. For that reason alone, we were maintaining the FiO2 60 to 70%. However, we had an arterial line, we were monitoring the blood gases, especially looking at any CO2 buildup that is happening. So child, once woken up, had dramatic improvement, tolerated transition from ventilator, was mobilized, feeding initiated, and we removed all the lines and tubes which accompany a post-op transplant child. They have 3-4 femoral lines on both sides, internal jugular, dialysis catheter. So all those things we are able to remove that early if we are able to wake them up and switch them over to HFNC. So case 3, there was a call received at 10 p.m. from a nearby clinic. 2-year-old boy presented in status epilepticus. Anti-epileptics were given. The child seizures aborted. Now was in post-ictal state. And history suggestive of some form of aspiration, little noisy chest was present. The vitals were stable. VBG, however, done at the local clinic itself showed a PCO2 of 56 and PaO2 of 60. Lactates were around 2. Retrieval was requested with parents. Child was retrieved by PICU team. Now, when we know that it is again a very transient event. Seizure happened, seizure aborted, the child is in post-ictal state. The whatever bradypnea and hypopnea happens in that phase is also easily going to revert once the child wakes up. And for that reason, even with CO2 of 56, we did not decide on any form of BiPAP or invasive ventilation. We just provided HFNC, and this HFNC is compatible with all our kind of computer inverter battery. If you take and fix the HFNC to that in the ambulance, it works beautifully. But nowadays, even the kind of next generation airwos which are coming will come with a battery backup, so that it is easy to transport them within the hospital and for long distance retrievals as well. So significant respiratory support for child because it was in post-ictal stage. We avoided intubation, and child remained in PICU for the next 24 hours and then eventually recovered. So that was the cases primarily to demonstrate the versatility, comfort, and the ease of use of the HFNC device as such. As Madam told, we are waiting for the COVID third wave. And what is the kind of consensus in terms of using HFNC in COVID children? The primary, in the first few months of pandemic, because of the fear of aerosolization during with both NIV and HFNC, the concerns were that it is going to make worse, and most of the healthcare workers are going to get exposed to aerosols of COVID and get affected. So the primary objectives of clinical management in COVID were primarily improving patient outcomes, example by avoiding need for tracheal intubation. Uniformly, all centers world over have demonstrated that children and adults, especially studied in adults, who were treated for hypoxic respiratory failure with invasive ventilation did poorly, because our understanding of the overall inflammation, thrombosis, pulmonary thromboembolism was poorly understood. And the things which made significant difference was when we decided to move away from invasive ventilation to other forms of non-invasive support and oxygen delivery devices, be it mask NIV, HFNC, proning. These were the measures that brought about a dramatic improvement in the outcomes. The other important objective of COVID management is maintaining the healthcare safety as such, and to prevent the increasing in widespread nosocomial infection. So all these things were studied for last 1 year, and now the recommendations are very, very clear. By the aerosolization with HFNC is not significant enough to cause increased risk as such. And the WHO says HFNC can be used in children, in adults with mild ARDS. In COVID, this is specific to COVID. The NIH recommends NIV in patients with acute hypoxic respiratory failure despite conventional oxygen therapy. The Society for Critical Care Medicines kind of suggests use of conventional oxygen therapy and NIV. Use HFNC straight away and maintain the patients on that, prevent intubations. And even the Australia-New Zealand group also finds the same impact. The side effects are very few. Very rarely there may be air leaks as such, but again, that can be mitigated if we are using it right, if we are understanding the physiology and the working of the machines right. So just coming to the summary of both the talks as such. So high flow nasal cannula oxygen therapy, also referred as HFNC, heated humidified high flow nasal cannula, involves delivery of an adjustable mixture of heated and humidified air and oxygen at rates that exceeds spontaneous inspiratory flow, that is up to 2 liters per kg per minute, maxed out to 60 liters. So that is what is HFNC. It offers distinct advantages over other modes of oxygen delivery and respiratory support without compromising ease of initiation. So if you use the HFNC machine, you will understand how easy it is to plug in, use it, clean it, decontaminate it. It gives excellent patient comfort, including better oxygen delivery than low flow devices and other face mask devices. It can be trialed in patients who can maintain their airway, who is alert and able to swallow, who does not have any other contraindications to its use, and who has some form of respiratory distress or hypoxemia. It should not, however, delay the advanced airway management in a patient deemed to require immediate endotracheal intubation. Sometimes HFNC can put the clinicians on the ground into some form of complacency, saying that, okay, we have started, FiO2 has little, the saturations have gone up, he looks little better, should I wait? And then CO2 jumps up to 70, pH drops to 7.1, and then there is a chaos of intubation. So when in the borderline patients, when you are putting the child on HFNC, we had to stand bedside for next 1 to 2 hours to see what physiological parameters are improving. And if there is an impaired mental status, risk of aspiration, or any other need for airway protection, it's better to go ahead, so especially something like a trauma. You have a facial trauma, mid-face trauma, the anatomy is distorted, or scalding burns or corrosive burns in the oronasal cavities, then it's better to go in for a definitive airway, because the anticipated edema will block the airway when we are using HFNC. Contraindications: hyperbaric respiratory failure, very clear. Facial anomalies, excessive oral and nasal secretions, actively child is vomiting, there is bowel obstruction, existing air leak is present, or agitation and confusion is present, predicting inability to tolerate. The child is really fighting it and is not able to tolerate, better to take over. After the appropriately sized nasal cannula and circuit is selected, heat it, titrate the flow rate, titrate the FiO2, and humidify it, and then and wait and watch for the response. And response to therapy can be measured by evaluating your tachycardia, tachypnea, decreased work of breathing, and improved oxygenation. So serious complications can occur, but it is less than 1%. That should not stop you from using this device. And it's the rates of complications are much lower compared to CPAP, NIV, and mechanical ventilation. So with that, I thank you again, and we can take the questions in the chat box. It is there.
Thank you, Doctor. The first question is it necessary to wean patients who are on bubble CPAP onto HFNC?
Madam, you want to take that?
I don't think it's really needed, because we use it as an alternative, isn't it?
Yes, so I also feel it is not needed. Bubble CPAP provides an kind of just slightly humidified oxygen, and the pressure of the water column maintains the airway stent which is there. Once the peak pressure, once the PEEP you have set is 6.5, I think below that, I don't think there is any requirement to wean onto HFNC as such. You can directly wean them to LFNC or to simple blow oxygen and titrate it and take off.
So, Doctor, in case the patient is less than 28 weeks, would the first mode of treatment be preferred as bubble CPAP or HFNC?
Ma'am, you want to take that?
Less than 28 weeks, I think ventilation only would be better. The HFNC below 28 weeks is difficult, I believe. Intubation would be required below 28 weeks. Only beyond 28 weeks, probably NIV would be better.
So I also agree. We can use CPAP if we are using below 28 weeks, mother is not steroided, child comes out with distress, and there is evidence of RDS. So then we can do Ensure followed by CPAP, and then maybe we followed by HFNC as such. But if the child is otherwise not in much distress, but the primary problem is apnea, then maybe you can give HFNC for that reason. But if it's a primary respiratory support you want to provide, I think better to go for invasive ventilation or CPAP rather than HFNC.
Thank you, Doctor. The next question to both of you is the 2 liter per kg body weight formula in pediatrics still applicable?
This is the upper limit for below 10 kg. You can start with 0.5 to 1 and then escalate up to 2, depending on the need.
Yes. So the 2 liters per kg body formula is still, as Madam told, it is the upper limit. So you don't usually go beyond that, because anybody who's requiring more than that will definitely fail the trial of HFNC. You can, as I told, you can do it during the apnea oxygenation while you're intubating. Children who are an altered sensorium, trauma, or some form of upper airway obstructions, which they are likely to fail the HFNC. We keep the HFNC, we initiate HFNC, it's not working, the saturation is still dropping. We keep the HFNC, we increase flows for 1 or 2 minutes, and then we go in with a rapid sequence intubation for these children. So during the period of that sedation paralysis, there is a constant flow of oxygen, which helps in the apnea oxygenation in these children. For all other practical purposes, 2 liters per kg body weight is an upper limit which can be used for children undergoing HFNC.
Right. Thank you, doctor. The last question is, any protocols in pediatrics for COVID, and is ROX index a defining factor?
COVID protocol already Dr. Chetan had described in detail. As such, the process-wise, it is not different. The initiation, monitoring, everything would be same, but only precaution should be taken more. As there was a panic not to use NIV, but now the protocols clearly say definitely NIV this HFNC can be used with proper precautions. And that it is more advantageous in a pandemic like COVID, where large numbers require respiratory support. HFNC definitely supports, and it reduces the cost and also reduces the PICU admission, but there is no specific protocol that is similar to other respiratory distress, something like pneumonia. And ROX index definitely helps in predicting, but it is not the only thing. We have to assess the clinical condition also, sensorium, retractions. Apart from the index alone, it won't be sufficient for monitoring. Yeah. Dr. Chetan would like to add anything?
Yeah, so whatever COVID patients we have managed so far, and we have learned from our adult colleagues significantly, the fear of invasive ventilation is significantly high. What our adult intensive care colleagues say, that once the COVID patient is on ventilator, mortality is 50%, whatever you do. So rather than concentrating on improving the oxygenation, the disease will run its course. We should focus on the medical therapy, which includes the anti-inflammatory therapies of steroid, antivirals, other biological agents to correct the inflammatory process. And meanwhile, while the inflammatory process is being arrested, the best way to support oxygenation is NIV, prone position, and HFNC. So invasive ventilation, because of its predilection of bad outcomes, especially with respect to COVID, is no longer advised even in pediatric age group.
Thank you, sir. I think we've come to the end of the question and answers. Any other closing comments that either of you would like to make to the audience?
So I think 20 years back, when we were studying in UK, the HFNCs had just come into the picture at that time, and it was very costly. We thought, why change the practice as such? But 10 years later, from 2010 onwards, now we feel that if there is a need to deliver oxygen, it has to be through HFNC. The prohibiting factor is, yes, there is a cost involved with respect to the circuit and the nasal cannula, which is there. But the comfort which it provides for the patients, and if cost is not a major concern, and if the government institutes are also buying and stocking up the consumables and the equipment maintenance is well done, I think HFNC should be there in every pediatric emergency, newborn units, one or two units in the oncology wards, in the respiratory care wards, and of course inside the PICU as well.
Yeah, definitely. I agree with Dr. Chetan. I would say, though COVID is disastrous to the world, I would say for pediatric units in India, at least it has done some good, provided no third wave comes. We've got a lot of